Hi, everybody. As you all know, we have been embarking on this amazing new process called Vital Lessons. Every month, we are doing another well-being based lesson, and we're doing it with our dear friend, Dr. Vin Gupta. And this time, he's brought a couple of other friends with us, Dr. Bayo Curry and Kathleen Green. And we're talking about something that a lot of the members, the first time we met, we said, what do you want us to cover? This is for you. And unfortunately, the federal government is not doing a lot of this anymore. And frankly, even if they were, one wouldn't trust, frankly, this is me, anything that comes out of Robert Kennedy Jr.'s mouth. But I do really trust, and I think we all do, Dr. Gupta and the other doctors that we've had, Dr. Adams last week, um, talking about ADHD and so many other issues that we see in schools. I thought was really amazing, Vin. So thank you for that. But today, it's a big lead up. We're talking about something that our members really wanted to talk about. Our members who are a disproportionately female workforce. And this is a conversation on perimenopause, menopause, and what you need to know. And for many of us who are postmenopausal, I kind of wish we had this conversation years and years and years ago. But I'm really glad we're doing this now. It is one of the most overlooked, perimenopause and menopause are some of the most overlooked, misunderstood, and under-discussed health issues affecting our members and frankly affecting much of the population. And we, as I said before, we launched this Vital Lessons program, and we partnered with Dr. Vin Gupta because people have been saying, our members have been saying, we're not getting straight answers from the people who are supposed to be giving it to us. And frankly, even when we are, there's so much misinformation and disinformation that is out there. And there's so much information that is out there that we're just trying to do what we can do. So whether it's mental health, whether it's infectious disease, or whether it's tonight's topic, which is hormonal health, we are trying to give people clear, trustworthy information and support with no spin and no stigma. So today, even I just teased about saying that I wish we had this before I went into postmenopausal, being a postmenopausal person. But whether it's in the workplace, whether it is generally a public health issue, whether it is a policy issue, the problem is perimenopause and menopause are real issues that affect people, obviously, principally women. They affect more than half the population. There's lots of different health effects that those of us who have gone through perimenopause, menopause, and now postmenopausal, we are. Our members, especially women in their 40s and 50s, are raising kids, caring for parents, managing classrooms, managing, their floors, on whatever kind of nurse they are, managing city services, and they're also at the same time managing hot flashes, brain fog, memory loss, joint pain, insomnia, mood changes, all with zero support, maybe all at the exact same time. And until 1993, women weren't even required to be included in clinical trials in this country. So many of the issues that affect women, we are really behind the curve at at best. And we need to have these kind of conversations amongst and between ourselves. And so I want to, without further ado, introduce these amazing doctors and experts, and I'm gonna introduce them all by their doctorate, each one of them. And this is our powerhouse group of experts tonight. And I'm gonna, particularly since we seem to have audio issues with me, I'm gonna actually ask Dr. Gupta to moderate this, and then I'll see if I can deal with the weird audio noise, which I don't quite understand why we have it, but we seem to have it. So Dr. Vin Gupta, who has been our partner in this series and a national voice for science-driven, compassionate-driven public health. What a concept. Isn't that what doctors are supposed to be? And I thank him every single day for his service and for his service to all of us now. And then there is Dr. Green, who I was going to introduce by her first name, but frankly, I'm going to introduce as Dr. Green, who is a board certified OBGYN and sexual wellness specialist who helps women every day navigate this stage of life with real tools and real care. And then there's Dr. Bayo Curry-Winchell, I hope I pronounced that right, who is a physician and a public health advocate who is unapologetic about addressing disparities in healthcare and fighting for better outcomes for all of our communities. And let me, as I turn it over to Dr. Gupta, let me say one more thing, which is this is not a lecture, it's a town hall. It's important for us to be able to engage. Oftentimes, this may be the only place where people feel safe to engage. So please drop us questions in the chat. Kelly Booz and I will be looking at them. We have a text chain going at the same time. Share what's worked for you if you care to. We gotta talk about these issues out loud. We gotta break stigma, and we have to start building solutions that where you feel seen and you feel heard. And so that's what this whole Vital Lesson series is about. And with that, Dr. Gupta, take it away.
Thanks so much, Randi. As always, I mean, just to emphasize this, I know this is our third, as Randi pointed out, in our National Town Hall series. Super jazzed about what we're doing and why we're doing it. Thank you to all of you. Your time is valuable. We're trying to be as time efficient with your busy lives as we can be to get you and your loved ones vital information. As a reminder, we're doing this monthly. We are coming out after each town hall with blog posts that summarize the key attributes, one-pagers of questions you should be asking your medical provider on key topics like youth mental health and ADHD, which we did last month with the former Surgeon General, and excited for this conversation. So without further ado, I want to bring in, and I really appreciate Dr. Bayo and Dr. Green being here, two big-time leaders in women's health across the country. And so this is going to be a little different than our prior town halls. Those were often, we'd hand the baton to our lead discussants and they'd take us through some slides. This is going to be a discussion. And so if you have questions in the midst of this, don't hesitate to just put them into the chat. We're going to try to get to as many as possible. So this is going to be just a running conversation. And so with that in mind, Dr. Green, wanted to start off with you. It feels like perimenopause specifically is getting a lot more attention of late. And I wondered if you could talk about what is perimenopause? And then two, what are some of the early, less obvious signs of perimenopause? And how can that lead to potentially misdiagnosis?
Thank you so much for having me. I'm very excited. So perimenopause is essentially the time before you go through menopause, which is going 12 months without a period. The average age of perimenopause is around 47, but many women will start getting symptoms kind of in early 40s. Many women may start having irregular periods, skipping periods, or really just worse PMS symptoms. Hormones start really fluctuating. I like to tell my patients that it's similar to when you get your very first period and you feel just kind of mood wise. You may feel much more moody right before your period, worse cramps, unpredictable acne, weight changes, all those wonderful things you probably remember when you got your first period. It really just starts coming back. Your hormones are literally going up and then down and then up and then down and then up and then down. And I'm glad that we're starting to talk about it, because for many women, they just felt like they were losing their mind. They felt like they were going crazy. They would talk to their providers, they'd talk to their doctors, and nobody really had any answers. And so often the first signs are they just feel like something's not right. For 2 weeks out of the month, they may feel great. And then 2 weeks out of the month, they feel horrible, like a truck hit them. They may start feeling like their metabolism is slowing down, they're gaining weight, they feel like their hormones are just kind of out of control, and they may start having body aches and not really sleeping well. And so that typically happens kind of in the mid 40s.
And is there an average length, would you say, to perimenopause as a transition directly into menopause? And just wondering, kind of level setting, how long should people expect to be in this period?
It's a really good question. When my patients ask me that, I say, do you want me to tell you the truth or do you want me to lie to you? It can last sometimes 7 to 10 years. Perimenopause can last approximately the same time. And we know that women of color have longer symptoms and more severe symptoms, and they're often undiagnosed and misdiagnosed. And those symptoms tend to last much longer. So, on average, 7 to 10 years for menopause and about 5 to 7 years for perimenopause as well.
Dr. Bayo, curious what you see in your own practice, and just adding on to Dr. Green's statements.
Well, first, thank you so much for having me. And I want to build upon what Dr. Green mentioned. In my practice, I often see patients who have shared that they've really gone through this journey of dismissal, or feeling that no one is taking their symptoms serious, or kind of what everybody can relate to. Am I going crazy? Is this really happening? And so the first step, I think, as clinicians, is really honoring that their journey is real, and that this is a factual thing that happens. And as Dr. Green mentioned, when you look at the fluctuation that happens with the hormones, and let's go a little bit deeper, those hormones are a part of how we go about our daily lives, and they impact our mood. And when you put all of that together, it can be very stressful when all of a sudden you were able to do things that you normally did. And now, even just waking up or even going to sleep can be a challenge. So I see a myriad of symptoms through my practice where, all of us are different. And as we go through perimenopause and menopause, we all have our own health journey.
What's the biggest misconception, and this is to the two of you, but Dr. Bayo, starting with you, that people have? Is it that, gosh, I'm feeling this symptom, fatigue. Let's take fatigue as an example. Do you think most people sort of in their late 30s into maybe their early 50s think of perimenopause or fatigue as potentially a signal symptom of fatigue or joint pain? Just wondering, it all feels so nonspecific. I say this as a son to a mom, that now we talk about this. She's like, yeah, I think I felt that way back when we were young. And I wonder if there's how much misdiagnosis is out there. If you can just comment on sort of the non-specific, I mean, these symptoms seem so non-specific, and wondering how you're sort of cutting through the noise to really give people the information they need. But Dr. Bayo, just wondering how the challenge of non-specific symptoms and landing at this diagnosis.
Well, when we highlight that they are quite nonspecific, we have, is it brain fog? Is it fatigue, joint pain? And to answer your question, we have to center on the fact that women were not even included in clinical trials. And we opened this discussion with talking about for over 30 years. Well, I like to pepper in, let's talk about that 30 years. That's the same as the amount of time that Netflix has been around. So when you really think about that, it really sheds a light on why we don't know as much as we should know when it comes to the symptoms that are included with perimenopause and menopause. And the other part that is really important that we highlight, this notion that we are supposed to just kind of be conditioned to deal with it, whether it's pregnancy, whether it's your period, whether it's menopause, where these are symptoms that as women are supposed to be normal. And for me, I kick out the term normal. It does not live in my practice. And for me, it's all about focusing on when I see my patient and when she shares with me what is happening to her, how she does not feel like how she used to feel. And I think that part is so important. That is what I focus on to be able to give the best care possible. So I cut through that noise by leaning into what is happening to my patient, leaning into individual care and making sure whatever uh, decision, whatever treatments, whatever things that we decide to do for your care, you're a part of that plan because I'm a part of it, but you are the driver. And that is my go-to when it comes to my practice, especially with all care, including perimenopause and menopause. And as a family medicine doctor, I'm so glad to be a part of this conversation because we are often the first touch point because we get to see all ages. I see women through all stages of their life. And it is important that we honor each stage in life so we can identify or prevent, conditions, complications, or be able to give people the best quality of life.
Really well said. Dr. Green, anything to add?
I agree with everything that Dr. Bayo said. I think also too is that two things can be true at the same time. I think that lots of the symptoms are perimenopause and they can be menopause as well, but we also don't want to miss other diagnoses as well. And so if I have a patient, we want to listen to what they're saying, but also just because you have joint pain, it may not be menopause. It may not be perimenopause. So let's not miss a diagnosis because we also have to remember that this is also the time when autoimmune disorders are also diagnosed in women as well. This is also the age where we may have rheumatoid arthritis or lupus or things like that, or increasing incidence of heart attacks and cardiovascular disease. So yes, palpitations and heart racing is very common during perimenopause and menopause, but that also means that I want you to see your cardiologist because this is also the time where we have to make sure that we're getting our mammograms and our health screenings as well. And so, yes, we want to listen to these symptoms, but we also have to rule out the bad things that it can be. And I tell my patients all the time, this is probably related to menopause and perimenopause, but I still need you to go see a cardiologist. I still need you to see, an orthopedic surgeon because that one-sided knee pain has been going on for a while and we've tried this. So let's rule out the other bad things that it could potentially be as well, because women are used to suffering through and toughing it out. So we also want to make sure that we are taking care of them as well.
I'm recognizing that
and I want to
one
build on
thing
that,
coming
what
out of
Dr.
this.
Green said. That part is so important.
No, we had a delay there. Dr. Bayo, please.
Sorry,
Go ahead.
Dr. Gupta. I just wanted to add what Dr. Green said. Okay.
Please.
I just wanted to add what she said. I think that
Of course.
what she mentioned is so important because we are not a one direction, one condition. We can have two things going on at the same time. So I really encourage everybody listening that make sure that you rule out all of the other possibilities or the added things that could be going on. Because unfortunately, if you don't, you could actually be missing something that could be addressed. So I just wanted to, build on what she said. That part is very important because our health, our care involves all areas of our body. And so just because one condition is pointed in one direction doesn't mean that there isn't a possible complication happening.
Fantastic. I love both of the points. And I think for a novice like me in this space, and recognizing in my pulmonary clinic, for example, I may see somebody who has, say, adult onset asthma, and there's so much might be going on when battling a chronic disease. And, myself, I'm getting versed in what are the questions you should be asking so that maybe I can direct a patient to somebody with your collective set of expertise to really dive deeper. For those like me, and just so that we close the book here on early signs and symptoms, and I want to move on to other related topics. What is there a checklist approach? And for everybody listening in, we're going to do a one-page digestible information sheet coming out of this, so you don't have to take notes. We'll make sure you have all the information you need in one place. But I'm curious, Dr. Green, would you, for example, is there a checklist of symptoms that we can sort of go through and say, gosh, you have 4 of these, therefore you're at high risk for perimenopause? Wondering how we can think about symptom checklists.
Well, one of the things that I start asking is, about your period. So if you're still getting periods, if you haven't had a hysterectomy or ablation, are your periods regular? Are they like they were before? And if so, start tracking them. That's a really great indicator. Are your symptoms cyclical? Do you get more headaches right around your period? Do you get worse sleep? Do you get poor moods kind of leading up to your period? If you're not getting periods, if you had an ablation or hysterectomy, it's a little bit trickier, but you may still have cyclical symptoms if you still have your ovaries. And so perimenopause is hormonal fluctuations, not the absence of hormones like menopause. So those symptoms that you're having, really try to keep track of them. Is that sleep really getting bad? Is the appetite increasing? Is the joint pain tending to get worse symptom wise around certain times of the month? That's a really good indicator. I also want to point out too that there's a small percentage of women, about 5%, that may have premature ovarian failure. We used to call it premature menopause as well. And so if you are having really difficulty getting pregnant and fertility treatment has failed, that could possibly be an indicator that you may want to see an OBGYN sooner rather than later, because you would need treatment, and we really need to discuss those options as well.
Dr. Bayo, anything to add?
For a checklist, I like to start with how to best advocate for yourself when you see your doctor. So there's a wide variety, like we talked about, of symptoms, and it can be really hard to close that gap and share what symptoms you have personally been experiencing. So I call it my 3 C's of being clear, concise, and confident. And I'm going to give just a concrete example. So instead of when you see the doctor, and often when we go and we see our doctor, we have all of these questions, all of these concerns, and all of us have experienced you go there and all of a sudden those questions have evaporated. Well, the 3 C's really help you kind of have that mental checklist so you can get your questions out and hopefully get the answers. So first, instead of being vague with your symptoms, saying, I haven't been feeling well, instead say, I have not been feeling well for at least a week, and it's impacting my quality of life. I can't even get out of bed. So when you are clear with not only your symptoms, you're able to deliver it in a very clear way so your doctor can hear you. And I start with that, Dr. Gupta, because you mentioned, that dialogue is so important. How do you hear your patient and get those answers from them? And then next is being very concise. We know we live in a landscape currently, unfortunately, of 15-minute visits. And so if you can really lead with your most pressing questions or those pressing symptoms in that checklist, that helps you get the most out of that appointment. And the last one is really being confident that you do know your body best. And we mentioned how, there's this, a lot of us have experience, including us as physicians, where you go to the doctor and you feel like, oh, maybe I shouldn't be bringing this up. Is this really an issue? So leaning into those 3 C's can really help you put your best foot forward and get the best care possible.
Excellent. I don't want to spend we can spend the entire time here on early symptoms and symptom checklists, but I think that gives us a lot to noodle on. And again, for all those listening in, and for those that couldn't join, we plan to post a concise summary of all the things you need to know to empower yourself and your families on this topic. There was a pre-submitted question, Dr. Green. I'm going to come to you on hormone replacement therapy. So I want to go from early symptom detection or sort of signs, early symptoms. What should you do about it? How do you ask all the right questions and communicate it effectively? Dr. Bayo, love that, the 3 C's, and how do you do it in a way that you make sure you get heard? So then ultimately, what do we do about it? And so, Dr. Green, on this question of hormone replacement therapy, HRT for short, can you talk to us about what HRT is and the risks and benefits? Because I think there's so much about risks and benefits of hormone replacement therapy. Over the last 30 years, we've read so much. Wondering if you can distill it down for us, specifically as it pertains to perimenopause.
Sure. So HRT, hormone replacement therapy, is estrogen and progesterone. Estrogen is the mainstay of what does the good stuff. So hot flashes, night sweats, helps prevent osteoporosis, and help prevent colon cancer. You always have to pair it with the progesterone for women with a uterus. The risk of HRT are low for most women, and by most women, HRT slightly increases the risk of breast cancer, blood clots, and stroke. That risk is low for women without a strong family history, a personal history of breast cancer, low for women without a personal history of blood clots or stroke. So for most women, HRT has far more benefits than risk. There's also increasing evidence that it decreases the risk of cardiovascular disease and potentially dementia as well. There's a lot of noise about HRT. There was lots of studies, and we can get into that if we have more time. The one point I want to make out about HRT is when we talk about the risk of HRT, risk is low when we're talking about FDA approved HRT. There's lots of HRT out there that's not FDA approved. And what I kind of tell my patients is how to make sure that it's FDA approved, your insurance will cover it, and you can get it from a local pharmacy, CVS, Walgreens, Costco, all of those. You shouldn't have to pay hundreds of dollars out of pocket for it. You should be able to get it from a regular pharmacy.
Excellent. And would you say that if somebody comes in, meets, say, checklist criteria for perimenopause, what's your first approach to treatment? Is it, let's start you on a trial of HRT at a low dose and escalate it? Would you consider non-pharmaceutical therapies? Wondering how you think about treatment initiation.
It's a really good question. So when I talk to a patient about treatment for perimenopause, they say there's three options for treatments. There's natural over-the-counter supplements, there's HRT, and then there's non-HRT. For perimenopause, by definition, women are still getting periods at some regularity. And for perimenopause, birth control is the mainstay of HRT because when we think about perimenopause, it's hormonal fluctuation. So for most women that are still getting periods, they're still fertile. So HRT is birth control, and that's a better option for most women. There's some nuances to that, but to prevent ovulation, prevent pregnancy, and help with the ups and the downs, birth control is safe for most women, and that's higher dosing than HRT, which is super low dose, just treats the hot flashes, the night sweats. There's also non-HRT options. So when I meet with a patient, I talk about all three options, risk versus benefits of all of those options, and discuss what may be the right option for each individual patient. And it really depends on how bothersome the symptoms are, health history, family history, and what they want to try first.
Quick follow-up, and Dr. Bayo, I want to follow up with you here. How many patients across the country, just as an estimate, and you may not have these fingertippy, but do you think have perimenopause? I don't know if there's studies, just an estimate, say in their late 30s into their 40s, and how many do you think are actually on some version of a medication?
I don't have a number to put behind it because I'm sure it's quite high. But when I think about trying to figure out what number that could be, the one thing that comes to mind, Dr. Gupta, is how many women are have not started on or don't know that they have the option to be on a medication. And I have a study to support what I mean by that. So yes, we've started to move the needle and more research with women's health and understanding how menopause, as Dr. Green mentioned, that HRTs can be helpful. And there was this thought that it could actually cause harm. Well, even though we have that at the forefront, there's a study by the National Institute of Health that said it takes up to 17 years for new evidence to translate into standard clinical practice, meaning all of the cool innovation, the new developments, the new opportunities to really have your symptoms under control or not feel like you're suffering through perimenopause or menopause. There's options there, but a lot of clinicians have not adopted those new practices. With that, that means there's so many patients out there who haven't had a discussion or the opportunity to discuss all of the available treatments that are there. So I focus on more of hoping that we can really get the word out. And that's why these discussions, these town halls are so important because it's a ripple effect. Someone listening right now is now maybe didn't know these options, and then they're going to share it with someone else. And I think that's how we're going to really be able to have a more accurate number of how many perimenopause patients have not received treatment.
And if a question that's actually came in real time, what's the right medical specialty? Is there a right medical specialty to be prescribing HRT for perimenopause? Endocrinologists, gynecologists, or is this something that you see PCPs manage? Just curious. I recognize both of you in family medicine and in obstetrics and gynecology. Wondering if you think that there is an ideal specialty that manages this, or is this something that any range of docs can handle? Dr. Bayo, let's start with you.
So I think it's the clinician's training. I think that's the important piece. As a family medicine doctor, when and I'll share my training, I was in a residency program that I had to do a specific amount of deliveries, vaginal deliveries. I had to assist with C-sections. I did a wealth of research and clinical rotations in women's health. I also did pediatrics. I did all areas. And so we call it the full spectrum of care. So therefore, I feel very comfortable treating perimenopause and menopause. Now, some people, some clinicians may not have had that background or training. And so I really feel it's important because you can have an expert in that field, but if they are not honoring your questions, your symptoms, or you don't feel seen and heard, it doesn't matter what their background is, because if they're not giving you what you need for your best health, they don't deserve to treat you, or and they may not give you the best care. So I think it's a wide spectrum. Doing your research is vital, and making sure whoever you see is important. And of course, OB/GYN, family medicine, those are top specialties that come to mind. Not saying it's limited, but I'll let Dr. Green jump in too, and I'd love to hear her thoughts.
I mean, I would agree. I think that anyone that's trained in HRT, so primary care physicians, family practice, OB/GYNs, I have endocrinologists that prescribe it as well. I think that there's a shortage of OB/GYNs and just a shortage of physicians in general. So I think that it's on the onus of the providers and physicians to really seek the knowledge. 1 in 5 residents graduating medical residency are trained in hormone replacement therapy and get enough women's health training. So any physician that is wanting to prescribe HRT, I think women are lucky to have providers that are interested. And most women walk away. 80% of women don't talk to their providers about their symptoms of menopause and perimenopause. And so I think any of those providers that are comfortable prescribing. And also, even if they're not comfortable prescribing, if they're willing to work with their patients and really look up the data and look up the information, I think that that's great as well. I mean, I'm sure Dr. Barrow the same way. If a patient comes to me, it's my patient, I don't know the answer to that. Let me look it up. Let's work together to get the answer. Let me call one of my colleagues on the phone and look at the dosing, and we can work together to get you the medication that you need.
Excellent. Randi, I think you have I'm going to kick it to you, Randi, real quick.
And I love the polling, and it's been amazing listening to all three of you. So I just want to say thank you very much. I mean, it just feels like people, and there's a lot of love coming from the chat as well. I feel like people are starting to say, "Oh my God, like somebody sees me. Like this is something that I've been going through." So thank you for seeing me, and I'm glad for the polling as well. Now, this is my question to all of you, and somebody from the chat also asked that question. What happens? Why are we stopping at premenopausal and menopausal? What about postmenopausal? Is there, if I'm still, and I'll just talk about myself, brain fog or sleep difficulty or, fatigue, is postmenopausal a thing too? And is there something that we can do about it?
I can tackle that one. The short answer is yes. We shouldn't be stopping at postmenopause. The majority of us will spend, if we're lucky enough, that have, a uterus, or if we've got a hysterectomy, don't have a uterus, we'll spend the majority of our lives postmenopausal. The short answer, and I can give the long answer, is we don't have data on treatment, HRT, for postmenopausal women. And so when we look at HRT or hormone replacement therapy, estrogen and progesterone, the data really shows about 10 years or age 60. That's what the data shows. We don't have good data farther than that. That's not to say that we can't continue it, but it's a risk versus benefits conversation. The goal of any medication, just pushing HRT aside, any medication, is we should do it as long as the patient's having symptoms. If a patient is still having symptoms past 60, let's talk about it. If a patient's not having symptoms, then really shouldn't be on really any medication. We wouldn't prescribe a blood pressure medication if the patient's not having symptoms, but I don't pry HRT out of a patient's hands at 60 and they're still sweating through their clothes at night. I don't know many doctors that do. So it's a risk versus benefits conversation. The one data that we do have, though, is we really shouldn't start HRT. And this is data, and we can talk about this as well, that women that are really 10 years post-menopause, there's good data that likely does increase the cardiovascular risk. However, that data is also a little bit shaky as well. We're still re-looking at the data. So again, this is really versus benefits. This is having a discussion with a patient and individualized risk. But if a patient is still having symptoms post-menopause, we have to treat them. What is the point of living if you're suffering, if you're not able to function in your job, if you're not able to remember meetings, if you're a high-powered executive or a school teacher, which is high-powered in my book. I have a child in school that is, if you can't remember things, what's the point of working? So it's all about quality of life. And so we just have to have that conversation about, should we be on medication? Is this the right medication? Is this the right dosage? And we would do that with any medication, just not HRT or even non-HRT prescription options for symptoms of menopause.
Dr. Bayo, okay.
Well, before the next one we do, we'll just make sure that I check out my audio to make sure that it doesn't create these annoying weird sounds that many of you are hearing.
Well, no, Randi, thank you for that question. It sounds good. Thank you, Randi, and Dr. Green, thank you for that. We're getting a ton of questions here, so in the interest of trying to leverage the two of yours expertise for the 25 minutes we have, I want to do some rapid fire, Dr. Bayo, to you. We're getting a few questions on, and I think it's important to clarify it, HRT in the setting of perimenopause, is that okay versus menopause? I feel like I can answer that, having listened now to the two of you for 40 minutes. But Dr. Bayo, if you can clarify, okay to start HRT or to ask the question to your doctor or your medical provider if you feel like you're experiencing perimenopausal symptoms, yes or no?
Yes, absolutely. Start that conversation now. If you even have an inkling of like, I'm not sure, this is maybe nothing, I want to empower you to say, yes, it is something. So absolutely start that conversation now.
Okay. And just real quick, because I think it's really important for people to self-screen. We talk about symptoms like brain fog, fatigue, joint pain. Please add in what is sort of the constellation here that should prompt that conversation on treatment?
Mood symptoms, vaginal dryness, pain with intercourse, sleep difficulty, weight changes.
Okay.
Those are the most common symptoms. Hot flashes, night sweats, irritability,
Okay.
brain fog.
Excellent.
Brain fog.
Okay.
Brain fog.
Brain fog. Okay. Great. And then Dr. Bayo, to you, if a few specific questions here on IUDs. I'm going to read it directly. If you have a Mirena IUD, you may not get your period at all. So how do you track where you are in the perimenopause, menopause cycle?
So the first thing is taking a baseline or an internal check of any new symptoms. So if you've had an IUD, you might have had it for a year or a couple of months. And I think starting with right when you have that IUD insertion, or if you've already had it, start cataloging or start writing down, oh, I've noticed that I'm having a hard time concentrating, or I feel more tired. So I call this the medical playbook. And so what it is really keeping track of all the symptoms that you are experiencing, especially when you start a new medication, or if it's an IUD or any sort of new kind of feeling that you've had. You're going to track your medications, you're going to track your symptoms. And through that, it allows you to have this amazing book of information about you. And so when you see your doctor, it really helps you kind of say, I've had this for 3 months, or this wasn't present 6 months ago. And then you've got this amazing information that reflects your own journey. And it's really helpful to have that conversation. So I say, if you have an IUD or your periods have been irregular, start now. It's not too late. Just start tracking your symptoms, and you can even just give yourself a voice text if it's too hard to write it all down. And that's a real way to be able to advocate for yourself when you see your doctor.
Great, perfect. Dr. Green, back to you. There's just so much to cover here. I do want to, so we talked symptoms. I want to leave folks with at least 3 take-home points, but at least 3 that they remember. We talked a lot about symptoms. We're talking about treatment, non-pharmacologic approaches, or maybe non-HRT approaches here to say be helpful for dealing with hair loss and thinning, something that keeps coming up. Anything you'd recommend, sort of traditional pharmaceuticals that are prescribed or non-pharmaceutical approaches for hair loss thinning concerns?
Yes, I'd want to make sure that we've had our thyroid checked and our vitamin D levels checked because that can sometimes affect hair growth as well. We look at pharmaceuticals or supplements, so minoxidil, the lotion or cream in your hair is over the counter. That can help with hair loss. Rosemary oil actually has been shown to be as effective as minoxidil as well. So that's a natural thing that you can just buy over the counter. If it doesn't work, it doesn't work. You typically have to try it for 4 to 6 months. I also strongly recommend seeing a dermatologist as well. There's so many things that can cause hair loss and thinning. And so seeing your primary care physician and seeing your dermatologist, different prescriptions. Minoxidil cream is over the counter, or foam. The minoxidil oral you have to get a prescription for, but really talking to your PCP for a full workup. There's other things that can cause hair loss too: stress, dietary changes, not enough protein adequate if you're trying to lose weight because you've gained weight. That can also affect hair loss and thinning as well.
And just to clarify, does hormone replacement therapy treat any hair thinning from perimenopause, menopause-like symptoms?
Tricky. It can sometimes increase the hair loss too, and that's why it's important to see a dermatologist. I have quite a few patients that actually lost more hair loss, had more hair loss when they started HRT, and that's where a dermatologist can really kind of help with that.
Okay. So I think really important to recognize here that there's a lot of quarterbacks for care in the setting of perimenopause and menopause associated symptoms, starting with their medical provider, your main medical provider, PCP, as the quarterback is useful because both of you have talked about different subspecialists potentially, or if you have a family medicine doctor, luckily I have a doctor like Dr. Bayo, maybe they can be the quarterback of all this care. But starting there and then sort of going forth from there is really important. Dr. Bayo, real quick on on natural treatments to include modifications to sleep and diet, to physical activity. Can you speak to whether or not is just quote unquote healthier living, eating differently, exercising every day, wondering, sleeping better? It sounds so easy for us to rattle off all these, recommendations. Wondering, one, is that a practical set of advice or recommendations in somebody kind of dealing with the spectrum of symptoms because of maybe perimenopause? Can somebody actually engage in non-pharmaceutical modifications to their lifestyle, or is it hard? And then 2, have you seen any efficacy from doing so?
So sleep hygiene is vital, but to your practical, can you do it? Well, I like to talk about taking one tiny step can lead to bigger achievements as well as sustainability. And so for sleep, including myself, so I like to highlight that I struggle with sometimes getting enough sleep. So one thing that I've done and I share with my patients is I pick a time of day that I am going to try to go to sleep, and p.m. And I don't get upset with myself if I don't make that 11 p.m. Instead, I celebrate that, hey, I made a step in saying, okay, 11 p.m., I'm going to try and do it. What I've noticed, though, there's a level of accountability. All of us listening have heard about with exercise. If you have this accountability buddy with yourself or something that reminds you, that's a way to get more sleep. And so really looking at setting a time and giving yourself grace. Maybe on Monday, you didn't make that 2 or 3 times out of the week, that's a win. The other thing is, if you are really trying to get enough, you go to bed and you're like, I'm struggling, it's been an hour and I'm not going to sleep. So get up, get out of bed, do an activity, and then come back to it. Because a lot of us have this mental battle with ourselves when we're like, why aren't we sleeping? Why isn't this happening? And it really doesn't help us. So if you can kind of, I call it a reboot, where you get a restart to try to go back to sleep, that's a real helpful way. And yes, I believe in diet. All of the things that are natural can also be a real way to implement better sleep, because when you do sleep, and this is the part of the efficacy, we know that getting better sleep means less stress on our organs, like our heart. So if you're not getting as much sleep, you're working a little bit harder. When that heart is pumping more, you have increased heart rate. All of those things can be cumulative and add to high blood pressure. You may not be drinking as much water during the day. And we know water is important with our overall health. So all of those things are possible. But the one thing that I would love for everyone to remember is start with one thing. One small thing can lead to bigger effects. And last but not least, because we've talked a lot about physical health, I can't help add in mental health. So I encourage everyone, and I do this for myself, I want everyone to pick one thing that you love to do every single day, even if it's just for 10 seconds. I love to dance. And so sometimes if you're in Reno and you see me, you might see me in the car doing this, a little shimmy. But what does that do? It provides a calming effect. It allows it's a mental and physical prescription for my own health and for my mental and physical health.
Excellent. We have there's so much engagement happening right now, which I really appreciate to all to listeners. I know it's 6:47 on the East Coast, 3:47 on the West Coast. So thank you, and especially thank you to the two of you here for leading this discussion. I want to make sure we get to everything. We're not going to get to everything, unfortunately, but do you want to ask a few questions on libido? We've had multiple questions come in on this specific topic. And Dr. Green, can sexual discomfort and or decreased libido, sort of lump them both in together, can they be treated without hormonal replacement therapy?
Yes, yes, and yes. Yes, that's the short answer. Yes. I mean, libido is
Okay.
so multifactorial. That's why there's no like female Viagra. But yes, I mean, lubricants, over-the-counter lubricants can help. Coconut oil can help. I have some great book recommendations I can email. We can send it in the after visit summary. But so yes, all of those things. There's also just topical, like vaginal estrogen that is not systemic. Almost everybody can use it, almost everybody. But that can also help. It can make it easier to reach an orgasm as well. There's some great book recommendations for improving libido, talk therapy. There's lots of great things that can improve libido. We could have a whole thing just on libido and sexual health. But yes, yes.
And I think what we might do, just for time efficiency purposes, Dr. Green, if you don't mind, maybe we could summarize that just for the post-webinar materials that go out, but that would be fantastic. Just maybe a few actionable pieces of advice from what we could point people to, but that's great. Dr. Bayo, anything to add there, just in terms of how do you improve libido during, after perimenopause, into menopause, and then post, there's a whole spectrum here. Just one of your thoughts and your advice.
There's a lot of stigma that comes with our own sexual health. And, whether it's the changes as far as feeling dry or feeling like a lot of my patients say, I have a new odor that I've never had before. And identifying those things that might be intercepting or disruptive to being able to have that intimacy that you are seeking, I would say start there and find a clinician that you feel comfortable with highlighting this is what's happening, and doing some research as well, because that way you come in armed with, these are my concerns, this is what I found online, and then share with me what are your thoughts on, as far as that clinician, about what's going on, because our libido is not only good for our physical health, but it is good for our mental health as well, in whatever space that you decide to partake in. And so that should not be left as a secondary. If anything, it is core to your overall health.
Excellent. I want to touch on 3 additional topics, and then we'll go free form here. I'm going to kick that to Randi. I do want to talk about, both of you work on the spectrum of women's health. And, I think we can't have this conversation without talking about challenges to access to care, and perhaps how different demographics experience what we've been talking about differently. And specifically, I know there's been a few questions out there, and the two of you really focus on this specific issue, which is, why is it that women of color typically have more severe menopausal symptoms specifically? If you could touch on that, maybe Dr. Green, starting with you.
We don't really know. I mean, we can think about why they have worse symptoms. We don't know quite the answer to that. We know that they often have less access to care. It's the same reason why women of color have higher rates of death from breast cancer. Even when we look at studies of they have same mammogram rates because they're offered less curative treatment options. But most likely, it's really just access to care and systemic racism. When we look at the parts of the country that have more minorities, they have less OBs, less women that are being cared for by physicians. And we know that women of color do better when they have physicians of color and women of color that look for them, that are caring for them. And parts of the country that were gutted by Medicaid and didn't have Medicaid expansion, those where the majority of minority women are. And so they have difficulty getting care, they have difficulty getting access to care, and then they're less likely to be heard by the physicians that are taking care of them. That's where telemedicine can really play a pivotal point in helping women advocate for themselves. Often they're also afraid to be seen as a disgruntled patient, and so they're significantly less likely to speak up for themselves as well.
I should note that, Dr. Green, I don't know if we said this in the tee-up, you work full-time for Maven Clinic, which is the world's largest digital clinic dedicated to women's health. Do you want to say a word on what you're building at Maven and potentially how folks could learn more about it and potentially access the services you're working hard to build?
Yeah, so at Maven, we are really bridging the gap. We know that brick and mortar healthcare is not working for everyone. And so we do full scope. We do pregnancy care, we do infertility care, we do menopause care, we do male midlife care, we do surrogacy, we do adoption, we're international. And so we care for women in all stages of life. And while we can't prescribe for all of our members, we help them find providers in their communities that can care for them. And we do care matching. So if we have a woman of color that wants to be seen by a woman of color, we will help them find a woman of color for them. If they want to be seen by a certain type of provider, we will do our best to match them with the provider because we know that they have better outcomes when they see a provider that looks like them.
Fantastic, thank you, Dr. Bayo. I'm going to come to you. I did want to say, and Randi, I'm going to make sure we have time for your close. So much of what the American Federation of Teachers does under Randi and her team's stewardship is Medicaid defense work. And I thought you encapsulated why that work is so relevant across a range of health needs, including access to perimenopause and menopause care, not to mention all women's health related considerations. So thank you for mentioning that. I think that is so, there's such a symmetry between what you just said, Dr. Green, highlighting that the gaps in care and what AFT is working every single day to advocate for its members and frankly for the country. So thank you for closing that loop. Dr. Bayo, wanted to come to you. I know you're medical director for St. Mary's Health Network in Reno, have a lot of leadership roles in the community there. Thank you for doing all that you do. In that vein, are there policies or support that workplaces should be providing to support women going through perimenopause and menopause? There's been a few comments in the chat about how women during their working careers, didn't feel comfortable, didn't feel like they were given enough time to even use the bathroom, and that there is potentially not that support in place within individual employers. I'm wondering if there needs to be best practices and how to start that conversation.
Yes, we need to do more. We have not even touched the surface of what needs to be incorporated when it comes to policies. And, there's been a lot of studies that have showed the gap in actually women showing up to work because they might have been having with perimenopause, menopause symptoms. Just overall work-life balance can just be difficult in general. And when we don't have the infrastructure to support the symptoms that are associated with just being a woman, because we also don't have the studies to show how important this is, we're missing the boat. And so some of the work that I've done, even through the society, I was the previous president of the Washoe County Medical Society, is really lobbying for legislation to incorporate policies that highlight that these are the things that are part of women's health. These things should be paid for, not just screenings, but what treatments are available. What things can we do if you need to take more time off because you are experiencing perimenopause or menopause symptoms? And let that be a part of the narrative, just like any other condition. And I think that is where more work needs to be done. And that's why having this discussion is so important. And it's something that within the organizations that I work at, we are continuing to push it forward. And how do we do that? It's events like this, it's sharing our stories, and that is a way for employers, organizations, the government to take note and continuing to push forward. And I know even all of us on here, we're not going to stop. As Randi mentioned, we have to continue to advocate and fight for women's health, to be at the forefront. We've been at the back seat for how long? We've got to keep going, and we will.
It's fantastic. Thank you, Dr. Bayo. Dr. Green, I'm going to give you a last word here, and then I'm going to kick it over to Randi. Any last comments?
I think the thing that I always like to tell my patients is that we're at a point now where nobody has to suffer through symptoms, whether that's period symptoms, perimenopausal symptoms, menopause symptoms, postmenopausal symptoms. So if you have a provider that's not hearing you, not seeing you, find a new provider. And if you need help with that, we can help. The North American Menopause Society has a great listing of doctors, but nobody has to suffer through. And sometimes it means searching for the right doctor. It means getting help advocating for yourself, but nobody needs to suffer through symptoms. Even if you think that you're not a candidate for HRT, there's other treatment options. There's non-HRT treatment options. There's lots of different treatment options that can help you, but nobody has to suffer through symptoms.
And sorry, North American, remind me what
NAMS. Yeah, North
NAMS.
American Menopause Society. It's a listing of doctors that have received extra training in menopause. You can go on their website. I can post it.
Okay. Fantastic. If you don't mind in the chat, that'd be great. And then we'll put that in the assets that go out after this. Just I'm going to be bothering both Dr. Green and Dr. Bayo even more afterwards, because this has been so great. But Randi, and I thank you to the two of you. What a wonderful just set of perspectives and experiences. We could do this for hours, I think. But Randi, I'm going to kick it over to you for your thoughts.
1 second. Thank you, Vin, so much for this, and thank you, Dr. Bayo. Thank you, Dr. Green. It just, as you can see in the chat, people feel so alone, and they feel like, oh my God, what's going on? Who can I turn to? How can I turn to someone without it looking like, without it getting weaponized, or without my getting undermined, or that kind of anxiety? And I think you just dispelled a lot of myths and helped people a lot tonight. And I really, really am grateful, speaking on behalf of all of our members. I'm grateful. And there's someone in the chat near the end who said, thank you, Dr. Bayo, Dr. Green, thank you, Dr. Gupta, and the AFT for this important discussion that was validating and helpful. And I think that that's what you did tonight. And I just really want to say how grateful we are. Dr. Gupta, the last one we did, when we really were talking about kids and anxiety and all of the things that get misdiagnosed or diagnosed in a different way. And today we're doing the same thing in some ways for many of our members themselves and what it means to them. So I'm really grateful to you. Sorry, I keep calling you Dr. Gupta. I know you as Vin, so I'm really grateful to you, Vin, for doing the series with us, so that we're really reaching out to people to try and create that kind of education. And something you said at the end, all of you, I don't remember if it was Dr. Bayo or Dr. Green, but it is a combination of both education and organizing. We have to organize to fight off the Medicaid cuts. We know if they happen, it's going to put all of us in much worse shape. But we have to also educate, because with all the disinformation and misinformation that is out there, in many ways, we have to educate first principles now about what's going on what the cuts mean, and dispel a lot of disinformation and misinformation. And I really, really appreciate that all three of you did that. And we are, as Vin said, we are fighting against the Medicaid cuts. There's several entities that are fighting against it, including there's one big fight that SEIU, NEA, AFSCME, and us are doing together. We've spent a bunch of money on ads and on outreach, particularly in the districts in which we think, maybe we'll have some, brave Congress people in Mr. Trump's party or President Trump's party will say enough. Hasn't happened yet, but we see people are really, really angry, and we keep at it, and we will keep at it this week and next week, and in the Senate, and on and on and on. And you can see how much of what we're talking about today is Medicaid adjacent and Medicaid dependent, particularly in rural areas and particularly in the South, where we already see a bunch of a lack of healthcare in so many different ways, and particularly in rural ways. So we're going to talk about other things as well in this series. This is the third of what we've done in terms of vital lessons. We've talked about measles, we've talked about DHD, and we've talked about menopause. And a lot of this is because of what people have asked for. So one of the things I heard today, and then I'm going to get to our slide for what we're doing tomorrow. It's a big week with webinars. We don't normally do 3 in a row, but this week we're doing 3 in a row. That I heard a lot about self-care. And I heard a lot about what can help us in terms of our own care and our own wellness. So I think, Vin, maybe we should do one of these things as well. I heard exercise, drinking water, not getting dehydrated, sleeping. If we can't sleep, tips about how to sleep. So I think some kind of way of really kind of doing something, maybe, in the middle of summer or at the start of the school year on kind of wellness, I think would be very, very, very appealing to people. And then we also want to say to people again, if there are other kinds of topics you want us to do, this is your series. It's once a month. So give us ideas about the other things you want us to do, and we will do it. On a different topic, there's been a lot of questions, and you see the slide up there. There's been a lot of questions about authoritarianism. What does it mean? What is going on in this country? What is happening? Why would, the Supreme Court Justice, Chief Justice Roberts say, if only we taught kids about civics more in schools, then they would know the rule of law. Who would have thought that in this country, we are really questioning whether or not we will have a democracy? And so a lot of people have been asking this question, and we will do more and more about this, but we thought we should really start with some experts on authoritarianism and whether or not we are backsliding from democracy into authoritarianism. Let's put that slide back up, Kelly, as I'm talking about it, if we can. And we have some really important experts who are helping us with this, and that webinar is tomorrow. Erica Chenoweth is a professor at the Harvard Kennedy School. Yvonne Moravec is someone who has actually stopped the backsliding in other countries. And for those who don't know, Reverend Dr. Cassandra Gould has really helped after some of the terrible shootings that have happened in the United States. I say this as we are happening on the 5th anniversary of the George Floyd killing in Minnesota. So we're really trying to have some experts, not so that we're identifying not just what authoritarianism is, but also what are the kinds of things that have worked in other places around the world and what we're trying to do in the United States. And so that is tomorrow, and that one is between Share My Lesson and the Shanker Institute and the AFT, and I hope to see you all there. And I just really want to say one more time to Dr. Bayo, to Dr. Green, to Dr. Gupta, so many doctors. It's so fantastic to see you all. But it's just thank you, thank you, thank you for today's really, really, really important discussion and conversation. And thank you, all of you who listened and wanted to engage. Thank you for being here. And thank you for all the work you do to make a difference in the lives of others in this country. Our 3 doctors and all of you who are listening and our staff, thank you. And I think we are off.
It's a rare condition this day and age to read any good news on the newspaper page. And love and tradition of the grand design, some people say, is even harder to find.